Welcome to the deep dive. Today we're looking at intra-arterial chemotherapy, IAC, for retinoblastoma. This is the most common eye cancer in young children, often showing up, before they're even 5. So effective treatment is just crucial.
Absolutely critical.
And what's really striking is how IAC seems to have changed the game, moving toward saving the eye, saving vision.
Right. It's a huge shift from older approaches.
Right.
And much easier on the kids systemically.
Exactly. So for our audience, neurologists, radiologists, neurosurgeons, we really want to unpack the technique, the potential pitfalls, the complications, and how to head them off.
Yeah, the nuts and bolts and the safety aspects. Very important.
So let's start with the procedure itself. It's a specialized endovascular thing, right, in an interventional neuroradiology suite. What's that setup like, especially under general anesthesia, with monitoring these small kids?
Okay, so precision is key from the get-go. You've got meticulous general anesthesia, continuous electrophysiological monitoring. And interestingly, something the sources really point out is using plastic wrap for the sterile field, not linen.
Plastic wrap. Why specifically avoid linen?
Well, it sounds minor, but those tiny linen fibers, they can potentially act as microemboli in these really delicate vessels. It's a subtle risk, but one you definitely want to avoid.
Wow. Okay, that level of detail really highlights how careful you have to be.
Yeah.
And getting arterial access in such young children, that must be tricky.
It definitely requires care. Usually it's the common femoral artery, ideally using ultrasound guidance. We use a 4F micropuncture needle.
Okay.
And once we have access, it's intravenous heparin straight away. You're aiming for an ACT activated clotting time between 200 and 300 seconds.
Right, get the anticoagulation sorted early to minimize clotting issues.
Exactly.
So access is established, patient's anticoagulated. Now comes the really fine work, the microcatheterization. How does that part proceed?
Yeah, this is where you navigate these highly specialized microcatheters, like a Marathon or a Prowler 10 with microwires, maybe a Synchro 10. The goal is to get right to the ophthalmic artery ostium. Ideally, you want to hook it directly with the catheter without needing the microwire right at the opening.
So minimizing manipulation at the actual target vessel opening.
Precisely. Using micropuncture and these microcatheters really helps streamline things, avoid some issues you might see with, say, larger guide catheters.
Makes sense. And all this is happening under imaging guidance, I assume. What are you using? What are you looking for?
Continuous fluoroscopy, that's your live map. And then, critically, you do a super selective contrast injection.
Okay.
That confirms your catheter tip is perfectly placed in the ophthalmic artery, but just as importantly, it ensures you don't have any reflux back into the internal carotid. That's a major safety check.
Right. You absolutely don't want chemo going into the brain circulation.
Definitely not. And you're also looking for the choroidal blush on DSA that confirms good antegrade flow, that the drug's going where it needs to within the eye.
And if the anatomy is unusual, sometimes the ophthalmic artery doesn't come off where you expect.
Yeah, that happens. In those cases, flat panel detector CT can be invaluable. Gives you that detailed 3D roadmap.
Okay, catheter's perfectly placed. Flow looks good. What about the chemotherapy agents themselves? Which ones are used and how are they administered?
The main players are melphalan, topotecan, and carboplatin. The dosing is quite specific. Melphalan, for instance, might be 3, 5, or 7.5 milligrams, but there's a cap, usually 0.5 milligrams per kilogram.
So it's carefully titrated for each child.
Very carefully. It's that balance enough to treat the tumor effectively, but minimizing systemic exposure. And the research suggests that for more advanced disease, using all 3 drugs often gives better results, better progression-free ocular survival, without necessarily increasing complications.
And the infusion itself.
Each drug is infused pretty slowly, typically over about 10 minutes per agent.
Got it.
Yeah.
Now, what about those tricky situations? Maybe the ophthalmic artery is blocked, stenosed, or has one of those unusual origins you mentioned. Are there workarounds?
Oh, yeah, you need a plan B, sometimes plan C. If direct access is tough, you might navigate through collaterals, maybe from the middle meningeal artery, or sometimes use balloon-assisted techniques if there's a lot of competing flow from, say, the external carotid artery branches.
Okay.
You can even directly catheterize some of those distal ECA branches, like the anterior deep temporal. Sometimes for the superficial temporal artery route, you even need manual compression on the forehead to direct flow properly.
Wow, that's intricate.
It can be. There's also using things like gel foam embolization sometimes to block off competing flow paths and ensure the chemo goes where you want it.
So once the infusion's done, what's the immediate post-procedure protocol?
First, reverse the heparin, usually with protamine. Then manual compression at the femoral site for hemostasis. We monitor pulse oximetry on the big toe on that same side, just checking distal perfusion.
And imaging checks.
Absolutely. An immediate repeat angiogram is standard. You need to confirm the vessels are patent, rule out any acute thromboembolic event right away.
And after discharge.
Typically oral aspirin for about 2 weeks, plus some topical ophthalmic meds. Then the next IAC session is usually scheduled about 4 weeks later.
Which naturally leads us to complications. With such a delicate procedure in small children, what are the main risks we need to be aware of, both during the procedure and later on?
Well, you have potential issues at the access site, the femoral artery.
Right.
Things like vasospasm, thrombosis, maybe even arterial disruption. These are a bit more frequent in the really small infants, say under 10 kilos. We tend to avoid closure devices in them because of the risk of stenosis.
Okay. Access site issues. What about more centrally?
You can potentially see carotid vasospasm or even an internal carotid dissection, though rare. Embolic events, stroke, are also risks. And a critical point the sources emphasize. If you see any intracranial reflux during that contrast check,
Yes.
you absolutely do not infuse neurotoxic drugs like melphalan. That's a non-negotiable safety step.
Understood. So those are systemic and central risks.
Yeah.
What about complications specific to the eye or the local vessels?
Right. You can get ophthalmic artery stenosis or even occlusion. Central retinal artery or branch retinal artery occlusion is a serious risk. Retinal or choroidal ischemia, sometimes that shows up subtly, maybe as pigment modeling later on.
Mm-hmm.
You can also see things like vitreous or subretinal hemorrhage, optic neuropathy, even eyelid edema or cataract formation.
And if you had to use one of those alternative access routes, like via the ECA?
Then you might see complications related to that territory, like forehead skin changes or burns if you went via the superficial temporal or periorbital edema.
So with all these potential issues, how do we actively prevent them? What's key for prevention?
Prevention really comes down to a few core things. First, meticulous technique throughout the procedure. Second, constant vigilance with imaging.
Like the angiography and fluoroscopy you mentioned.
Exactly. Real-time fluoro during and angiography immediately after are crucial for catching any vessel problems or clots early. Then, longer term, MRI is really useful for assessing late complications, hemorrhage, ischemia, changes in globe volume. Ultrasound's good for quickly spotting something like a vitreous hemorrhage.
Okay.
And third, it's strict patient selection. You know, maybe excluding patients with really significant vitreous hemorrhage up front, or those whose vascular anatomy looks particularly unfavorable or risky.
Right, and radiation safety must be a big consideration too, especially in kids.
Huge. The ALRR principle, as low as reasonably achievable, is fundamental. Minimizing radiation dose while still getting the necessary images is paramount.
It really sounds like IAC has fundamentally changed retinoblastoma treatment, moving towards preserving the eye and vision in a way that wasn't always possible.
It truly has. But it underscores the incredible level of expertise needed in interventional neuroradiology to do this safely and effectively.
Definitely. The technical skill involved is immense.
And you know, the techniques are always being refined, improved.
Which leads to a final thought. Given these ongoing refinements and the particular challenges of treating the very smallest patients, what do you think the next steps are? What future innovations might help us get even more precise, ensuring not just saving the eye, but really optimizing long-term vision and quality of life for these children?
That's the key question, isn't it? Pushing for even better precision, even better outcomes long-term. Lots to think about.